For the next talk, I invite Dr. Abhilash Nair to talk on target IOP, initiating medical management for glaucoma.
At the outset, I'd like to thank Dr. Manoj for this opportunity. And yeah, my talk is Target IOP and Initiating the Medical Management of Glaucoma. So, the aim of our treatment is to maintain the quality of life of the patient. And this is mainly by maintaining the visual function at a sustainable cost. So when we think about starting a medication for the newly diagnosed glaucoma patient, there are a lot of factors which we as clinicians do not really think about. And I think Dr. Rizana has touched upon a lot of those factors which are very important in management of glaucoma. We always talk about drugs and surgeries and everything, but from the patient side, there are a lot of psychological and social factors which we also need to be aware of, even if maybe we are not having time to go into. But the aim is to avoid blindness for the patient, and that depends upon a lot of factors which we have to look upon when we start our treatment. So a lot of the quality of life of the patient depends upon the personal preferences of the patient. And anybody who has been diagnosed with a disease would like to always maintain their personal lifestyle. So that will depend upon what sort of hobbies they have, what are their preferences, what sort of activities they have, what occupation do they have, how much of social support they are getting from the others around them, and of course, general health of the patient, what all medicines they are having, what are the side effects of the medicines, and what are the effects our medicines are going to have on those diseases. So the cost of glaucoma is not just the cost of the medicines that the patient is buying. It also includes the cost of the investigations the patient has to do, the person who has to accompany the patient to the clinic, the social burden of the disease, and the psychological trauma. Always establish the severity of the disease, and that is you have to check the baseline IOP, which may not be easy when you are having a patient who is already on drugs. You may not be able to stop all the medications to check the baseline IOP. You can always take a history, and always the baseline IOP includes at least 3 measurements taken at different times of the day. Field changes are important to note how much of the visual function patient is having at that time, and always assess the risk of progression. The risk of progression includes the age of the patient. The patient is having at a younger age when diagnosis occurs. That means the risk of progression is more through the lifetime of the individual. The intraocular pressure, any other risk factors the patient may be having, genetic predisposition to glaucoma, type of glaucoma, etc. Now, all this being said and done, the patient is always going to be worried about the functional damage the patient is going to face during his lifetime. Like maybe an inability to drive, patient may suffer falls due to his decrease in field of vision. The reading may go down, and finally, a lack of awareness or orientation around his surroundings. Now, staging of glaucoma can be done by many methods. The ONH examination is easiest to be done, but it is more or less subjective. It depends upon the pupillary size, what sort of examination you are doing, how experienced you are at the clinic. And it should always correlate with the objective methods that we are doing for the patient, the test that we are doing, OCT or fields or whatever. DDLS is good, given by Spaeth et al. I'm not going to the details due to lack of time. It's very good, but it's cumbersome to follow for each patient. Perimetric staging is easier if it is well done, and it has to be repeated and make sure that there is no learning curve. And a mean deviation of less than 6 is an early perimetric glaucoma. Moderate is 6 to 12, and severe is more than 12 decibels. Of course, scotomas within 5 degrees of fixation means it is an end-stage glaucoma. And as I mentioned earlier, the patient is probably more worried about the lack of contrast, the restriction in his daily lifestyle, and inability to do his preferred activities. There are many classifications regarding staging of glaucoma. And regarding coming to glaucoma treatment, so this graph is taken from European Glaucoma Society, and it shows the visual degradation during the lifetime of an individual. So A is the normal person. Everyone has a decrease in the visual function. and the other alphabets B to E are different patients. So we can see that some patients like E are very fast progressors. So those patients require very aggressive treatment. B and C patients have similar amount of visual disability, and the rate of progress also similar. But the difference is that C patient has been diagnosed with the glaucoma very early in life. So the risk of progression is much more in patient C compared to patient B. So patient C has to be taken care of much better than patient B. And D is progressing at a very slow rate. So in patient B and D, we probably need not even treat them, just observe them. Coming to the topic proper, target IOP. Target IOP, there are lots of definitions. I'm not going to read all of them, but it is the upper limit of IOP that slows the rate of glaucoma progression sufficiently so as to maintain the patient's quality of life. Now, there are important considerations. The target IOP is a dynamic figure. It's not set in stone. It has to change as you treat the patient. So if you feel that the IOP is not enough, the patient is progressing, then you may have to lower the target. If you feel that the patient is having complications and the glaucoma is not progressing as much, then probably you can maybe even raise the target. It's always a compromise between the visual loss and the cost of therapy. Now, everything I've been mentioning has been taking the glaucoma patient as a whole. Target IOP is separate for each eye. It's not the patient's target IOP, it's the eye's target IOP. So again, from European Glaucoma Society, these are the considerations that you must take into account when you set a target IOP. Now, target IOP can be either a percentage reduction, could be a threshold IOP, or it could be calculated using formulas. There are numerous formulas available. There are numerous nomograms available. We usually don't follow them. I think Jampel's formula is the most commonly used formula. All the big RCT studies used percentage reduction to, as a guideline to note how much of the glaucoma is progressing. And according to those, the ocular hypertensives were supposed to have a reduction of at least 20%, mild glaucomas 25%, normal tension glaucomas 30%, moderate 30 to 35%, and advanced disease 40%. These are AAO guidelines. If you want a threshold IOP, again, that is also available from these studies. And if it's a suspect you may have to reduce it less than 24. Early glaucoma 20 or less, moderate 17, and advanced 14 from the AAG study. So this is a graph that shows the initial untreated IOP with the percentage reduction that you want. So the person is having a 25 initial IOP and you want a 40% reduction. That means you can see that around you need 15 millimeters of mercury as the target IOP. So finally, when you start the treatment, you have to keep in mind the patient characteristics and the drug properties. And once you select a drug, you follow up the patient and find if the target IOP is being achieved. If not, you can probably add a new drug or substitute and make sure that the target IOP is reached. All my slides are from guidelines from the European Glaucoma Society as well as the Glaucoma Society of India. Thank you once again for your patient listening.
Thank you, Abhilash.